To accurately diagnose pathology in magnetic resonance imaging, we rely heavily on generating precise tissue contrast. A primary method for achieving this is by isolating the pure T2 relaxation effect of the tissues being scanned. But capturing that specific signal presents an immediate physical problem. After the scanner applies an initial 90-degree excitation pulse, the required transverse magnetization decays far too rapidly to be clinically measured. This rapid loss of measurable signal is formally known as free induction decay, or FID. FID is driven by what we call T2 star effects. T2 star is a combination of two distinct factors: the true desired T2 relaxation of the tissue and the unwanted inconsistencies, or static field homogeneeities, inherent in the MRI machine's main magnetic field. To strip away those hardware-induced artifacts and measure the underlying true T2, the operator must utilize a specific temporal intervention, the spin echo sequence. A single excitation pulse is mathematically insufficient for clinical imaging. We require a precise mechanical intervention to rescue the decaying signal from the static field anomalies. This graph charts transverse magnetization over time following an initial excitation. At time 0, a 90-degree RF pulse is applied. This creates maximum transverse magnetization, pushing our signal to its absolute peak. But almost instantly, we see an immediate steep drop-off. This curve is the reality of T2 star, or free induction decay. Compare that to the much slower, gentler decay curve that represents pure T2 relaxation, if the field were uniform. The vertical space between the steep T2 star curve and the shallow true T2 envelope represents the raw signal lost entirely to static magnetic field inhomogeneities. The objective of our sequence is to find a mechanism to force the signal to bounce from the bottom of the FID curve back up to that true T2 envelope. The spin echo sequence does not create a new type of signal. It uses a temporal trick to recover lost amplitude, forcing the sequence to touch the true T2 curve at one specific calculable point in time. This dual pane layout correlates the sequence timing on the top with the physical movement of proton phase vectors on the bottom. Step 1 occurs at time 0 with the application of the initial 90-degree RF pulse. This pulse flips the bulk magnetization perfectly into the transverse plane. Every proton vector precesses completely in phase, yielding that maximum signal we saw on the graph. As time advances immediately following the pulse, static magnetic field inhomogeneities cause some protons to experience a slightly stronger magnetic pole and others a weaker pole. This variation causes them to dephase. We can categorize these separating vectors into two groups: the red leaders, which are moving faster because they sit in a stronger field, and the blue laggards, which are moving slower in a weaker field. This physical fanning out, this loss of phase coherence in the transverse plane, is the exact mechanical cause of the rapid FID signal drop. To reverse this fanning, we introduce a specific time point t on our timeline. We define this variable as TE/2, or half the time to echo. Exactly at TE/2, step 2 occurs. The scanner fires a 180-degree RF rephasing pulse. Mechanically, a 180-degree pulse is simply an RF pulse applied for exactly twice as long as the initial 90-degree excitation pulse. This has a profound geometric effect on the transverse plane. Every fanned-out vector is instantly rotated 180 degrees across the axis. The result is a complete geometric reversal. The fast, red leader vectors have essentially been teleported to the back of the pack. Conversely, the slow blue lagger vectors are now physically positioned at the front. Here is the crucial caveat: the static magnetic field inhomogeneities have not been fixed. The fast vectors in the back are still experiencing a stronger field, and therefore still moving faster. The slow vectors in the front are still moving slower. The 180-degree pulse does not repair the broken magnetic field. It alters the proton's geometric position within it, forcing the fast protons to cover more ground. It turns the field's inconsistency into the very mechanism that will solve the problem. As time advances past TE/2, a mechanical race begins in the transverse plane. Because the fast vectors are now in the rear, they inevitably catch up to the slow vectors over an identical duration of time t. This brings us to time 2t on the timeline, explicitly labeled as TE, or time to echo. Exactly at TE, the climax of the cycle occurs. All vectors perfectly catch up with one another and restack. Because the vectors are completely in phase again, the transverse magnetization signal peaks. This peak is the spin echo. Notice that this echo peak does not reach the original 90-degree maximum. Instead, it touches the theoretical pure T2 decay curve. The signal that was previously lost to fixed field inhomogeneities was recovered by the 180-degree flip. This guarantees that the remaining signal decay is exclusively due to the tissue's own microscopic properties. By forcing this restacking and measuring the echo exactly at TE, the operator successfully bypasses the machine artifact to capture a pure tissue-characteristic T2 measurement. When we zoom out to view the sequence as a continuous operation, we see the complete unit of work. Following the measurement of the echo, there is a variable time gap, concluding with the firing of a new 90-degree excitation pulse. The total time elapsed between the first 90-degree pulse and this newly fired 90-degree pulse is a critical parameter. We label this complete interval as TR, or time to repetition. A single echo at TE provides only a fraction of the necessary data for an image. This entire TR cycle must be repeated hundreds of times to systematically fill K-space and build a single clinical slice. The chronology is absolute. An initial 90-degree pulse fires. A 180-degree pulse fires at TE over 2, the echo is measured at TE, and the entire cycle restarts at TR. This table outlines the clinical trade-offs of utilizing the spin echo sequence in a diagnostic setting. The primary advantage is the production of a high signal-to-noise ratio. The mechanical rephasing of the echo ensures a robust, distinct signal block. Furthermore, it yields true T2 weighting while effectively minimizing susceptibility artifacts that frequently occur at the boundaries of metal or bone. The first major disadvantage is time. The sequence requires long scan times because the operator is forced to wait through the temporal delays necessary for the vectors to dephase and manually rephase. The final disadvantage is elevated RF power deposition, or SAR, absorbed by the patient. This is due to the sequence's heavy reliance on lengthy 180-degree pulses compared to gradient echo alternatives. Despite the physical penalties in time and power, the spin echo sequence perfectly isolates tissue characteristics from hardware limitations, securing its place as the foundational standard for diagnostic T2 imaging.